All right, hello everyone, and thank you for joining the program today, an overview of the Women's Health Connection and Colorectal Cancer Control Programs. My name is Kristen Power, Director of Communications at the Nevada Cancer Coalition, and I will be serving as moderator for the webinar. The Nevada Cancer Coalition presents this webinar with funding from the Nevada Division of Public and Behavioral Health's Women's Health Connection and Colorectal Cancer Control Programs. So just a little housekeeping before we get started. Please make sure that you're logged onto the webinar using the link that was provided in your confirmation email so that you can follow along with the presentation slides. We have muted all participant phones to provide the clearest audio possible. You will notice a chat box in the bottom left corner of your screen. If you have any questions, please type them into the chat box and we'll address those questions either at the end of the presentation or in between speakers. A recording of this presentation along with a link to the post-test are available on nevadacancercoalition.org on the cancer screening training modules under the Healthcare Providers tab. If you're pursuing Nevada Cancer Coalition's cancer screening certification, please be sure to complete that post-test so that you'll receive credit. Today's webinar is presented by Kellie Ducker, Women's Health Connection Coordinator at Nevada's Division of Public and Behavioral Health, and by Dena Miguel, Preventive Care Director at Access to Healthcare Network. The objectives of today's webinar are to describe the program history and purpose of both the Women's Health Connection program and Colorectal Cancer Control Program screening programs, to discuss each program's eligibility, forms, processes, and systems, to review current program-specific screening guidelines for breast, cervical, and colorectal cancers, and how and why they differ from national guidelines, and then to provide an overview of specific roles within each program. And then lastly, we'll identify additional resources to assist individuals who are ineligible for either screening program. I'm going to go ahead and turn it over to Kellie Ducker to review the information on the state programs.
Good afternoon. This is Kellie Ducker from the Women's Health Connection program. I would like to thank everybody for joining this afternoon for our maiden voyage of the Community Health Worker webinar series. The Colorectal and Cancer Screening, Women's Health Connection Cancer Screening Programs, Nevada's Breast, Cervical, and Colorectal Cancer Screening Programs, also known as within the state as the Cancer Screening Programs, are located within the Chronic Disease Prevention and Health Promotion section within the Division of Public and Behavioral Health, Bureau of Child, Family, and Community Wellness. The Bureau of Child, Family, and Community Wellness, which encompasses the Breast and Cervical Cancer Screening Program, which is also known as Women's Health Connection, and the Colorectal Cancer Screening Program, also known as CRC. Women's Health Connection screens approximately 7,000 women a year, as the Colorectal Cancer Screening Program screens approximately 1,000 women a year. Both programs are federally funded through a cooperative agreement through the Centers of Disease and Control. The CRC program was authorized in 2015 for a 5-year period, while the Women's Health Connection was authorized for a 5-year period beginning on June 30th, 2017. The DPBH entered into a multi-year contract in 2011 with Access to Healthcare Network to administer both programs components for the CRC program and Women's Health Connection grants. The partnership increases access to primary and specialty care services for breast, cervical, and colorectal cancer screenings. First, we're going to go over the history of both of the programs, and then we'll go into some other information. So the Colorectal Cancer Screening Control Program, it started out in 2005 to 2009. The CDC conducted a 4-year they call it a demonstration program at 5 sites to see if there was actually a need for colorectal cancer screening programs. What they found in that demonstration period was that the program provided the United States Preventative Services Task Force recommendations, also known as USPSTF recommendations, for the colorectal cancer screenings, and they serve low-income men and women who are uninsured or underinsured. Following that demonstration period, the CDC received additional fundings to support the colorectal cancer control program in 22 states, 4 tribes, organizations, effective fiscal year 2010. And in that time, that's when Nevada actually received the colorectal cancer control grant, was in 2010. The CCSD goals were to increase cancer colorectal screening rates to 80% among all people over the age of 50, increase the percentage of people who have been screened regardless of income or insurance status. Grantees also used through the community guide evidence-based interventions. We also refer to them as EBIs to make it short. And up to 30% of the awarded funds were used to provide colorectal cancer screenings to low-income men and women who were uninsured or underinsured for the colorectal cancer screening. The colorectal cancer screening program. So in 2015, July 2015, Nevada was awarded a 5-year funding cycle to support partnerships within health systems, to institute screening programs, direct screening and follow-up services for individuals aged 50 to 64, and implementation of priority interventions through the community guide. This approach allows grantees to implement targeted activities on a feasibility scale and collect data that shows the program's impact. There's been a lot of studies actually when this grant had started in 2015, and they're finding very large successes in regards to the way the colorectal program with their screening rates have actually increased quite a bit. The colorectal program is separated into 2 different components. We always refer to Component 1 and Component 2. The Component 1, also known as the health systems component, which is to partner with specific health systems to help increase or implement evidence-based interventions and other strategies that we deem that would help them increase their screening rates. Component 2 provides the direct services and follow-up services for the individuals aged 50 to 64 who are asymptomatic, at risk for colorectal cancer, have inadequate or no health insurance for screening, and are low income. The history of Women's Health Connection program. In 1990, Congress passed the Breast and Cervical Cancer Mortality Prevention Act, which authorized the CDC to function as the National Breast and Cervical Cancer Early Detection Program, known as the NBCCEDP. In 1990, it funded 67 programs, 50 states, District of Columbia, 5 U.S. territories, and 11 tribes and tribal organizations. The Women's Health Connection program, for about 5 years before, from like 1985 to 90, they had done quite a bit of research in regards. Actually, they started out with the breast cancer and realized that cervical cancer also needed to be addressed in their demonstration period. In the year 2000, Congress passed the Breast and Cervical Cancer Prevention and Treatment Act of 2000, also referred to as Public Law 106-354, which allows if a woman is diagnosed with cancer outside the program, they have the ability to come in through the program and be screened through Medicaid services. In 1997, the state of Nevada, DPVH, received funding for the NBCCEDP to conduct Women's Health Connection program. To date, Women's Health Connection has continually been funded through NBCCEDP. We have provided breast and cervical cancer screening services to 58,470 women, provided 190,475 mammograms, covered diagnosis of more than 690 breast cancers and 992 cervical cancers or premalignant lesions. This last year, during the 27th legislative session, a bill was introduced, AB 388, to make an appropriation of $500,000 each year for 2 years to support breast and cervical cancer screenings for and underinsured women in Nevada, which has been the first time ever that Nevada has ever received any monies through legislation to screen for any of the chronic diseases. So this was a huge milestone. I think Nevada, before this was passed, there was only one of 2 states, Nevada being one of them, who's not received any state fundings. So an overview of the Women's Health Connection program. The current funding, so what the CDC did was they took the successes of the colorectal cancer screening control program and basically has mimicked it. So the funding is to provide breast and cervical cancer screening services to uninsured and underinsured women. We're supposed to, just like the colorectal, implement the key evidence-based strategies to reduce structural barriers to screening within health systems. And these outcomes will be achieved by connecting women into target communities to screening services, eliminate barriers, and we also utilize the community guide to support EBI strategies. Do you have any questions? I would like to introduce Dena Miguel from Access to Healthcare Network.
Good afternoon, everyone. Thank you so much for joining us today. So as most of you know, I could see who's on the phone. Some of you have been through my spiel before. Through Access to Healthcare, we're a statewide nonprofit providing over 200,000 Nevadas annually with access to health. The bubbles you see before you are all the different programs that are under our umbrella. Women's Health Connection and Colorectal definitely being one, but we don't just screen when the women call through our call center. We don't just screen for those programs. We actually screen for every one of these programs, so they could potentially qualify for multiple programs under Access to Healthcare, and almost all of them are free. Women's Health Connection and Colorectal Cancer Program Introduction. AHM provides the following services. We do the eligibility determination, the care coordination, the data entry, the reimbursement, and then we help them find resources for treatment. And all the providers, we're constantly recruiting and looking for more providers for our program as it grows. So the eligibility criteria for this fiscal year 18 is women ages 21 to 64 at or below 250% of the federal poverty level, not eligible for Medicaid or Nevada Marketplace insurance product, are uninsured or underinsured. For the underinsured, it's the high deductibles and copays that we would help with. Methods of enrollment into Women's Health Connection. So there's 2 different ways you can enroll through us. You can enroll at the PCP's office. So once the woman makes the appointment, the provider then, we give them a cheat sheet, and so they know that they have to meet age, they have to be a Nevada resident, and income. Once the PCP's office has deemed them eligible, they fill out the paperwork, they give them a card that we supply everybody with, then they put them on the program and do all their services, and then fax us the enrollment. The second way through our program is you can go through AHM's helpline call center, and then they screen the woman, fill out all the paperwork, and then mail it to her also with a provider list that she could choose a provider from, if she hasn't already established that during the call, through the call center. So enrollment limits. So every year is what I sit down and do is the state pulls different reports for us, and then I take those reports, put them against what I've been tracking to see
who's used what. So when I make the next year's set of cards that you get, and that allotted amount is determined by how many cards you used the previous year, how many cards not only did you use, but the enrollments were filled out correctly, we were able to bill on those, we got results timely, all those things we keep track of, and that's how we determine that. If you feel you don't have enough cards one month and you needed cards, you are always more than welcome to call us to see if we have more that month. Sometimes we will, sometimes we won't. It just depends if I could pull from another provider who isn't using their cards. Because again, it's not unlimited funding. We do have a set funding amount, so there's a set amount of cards and women we know we could screen at the beginning of the year. Cervical screening services are ages 21 through 29. They get the annual pelvic, the PAP, the diagnostic services after any abnormal screening result, and a referral for treatment. Age 30 to 64 years old, you get the annual pelvic screening, the PAP test or co-testing, the PAP and the HPV test as recommended by the examining clinician. Diagnostic services after an abnormal screening result, and again, we would refer out to treatment. Breast screening services is ages 40 to 64, which you have no idea how awesome it is to be able to say that we are now providing annual screening mammograms. So it's their annual clinical breast exam, which is considered a CBE, an annual screening mammogram, and diagnostic services after abnormal screening results, and again, referral for treatment. So now we'll go in a little into colon. The eligibility criteria for colon is men and women. It's 50 to 64 years old. Now with Women's Health Connection, we have a little bit of movement in the age, not in colorectal. It's 50 to 64 years old, and we can't change that at all. It's at or below the 250% of the federal poverty level. They have to be uninsured or considered underinsured. Again, high deductibles and copays. They can have no chronic GI conditions, cannot have any of the following: Crohn's disease. When you're looking at these, before you could see the list I'm going off of, when you're looking at this list, we've noticed an increase where people are saying they have that, and then they go through. We get them through, but it does mess everything up on the colonoscopy side of it when they don't tell us that they have these issues in the beginning. They have to be asymptomatic, cannot have any of the following: rectal bleeding, constant diarrhea, blood and stool, consistent constipation, unexplained weight loss, and lower abdominal pain. Now with this, when people say what is consistent constipation, it doesn't mean that they were constipated last week for 2 days. It means like they literally have been constipated for the last couple months. Unexplained weight loss, it's not like 2, 3, 4 pounds. Generally, it's like 5, 10, 15 pounds, just so you know when you're asking the questions at the provider's office. Enrollment and program process. Provider's office will determine eligibility. They'll hand out the enrollment form to the eligible patient. They'll complete the LabCorp rec form in the highlighted areas and the specimen tube, distribute fit kit to eligible patient, review and make sure enrollments are completed before submitting. That's super important for both programs, that everything's filled out. If it's not filled out, if you just put NA. But what we really can't stress enough is the questions on those enrollments we have to have, which I'll go into later. Fax, email, mail enrollment, and consent to access a health care coordinator within 2 to 3 business days if possible. If not, within the week by the Friday, but no later than the following Monday. With the fax and email, we also have our secured FTP site that you could send it to, but we are really trying to go paperless at this point. Enrollment and program process. Patient will sign the consent form, fill out enrollment completely, perform test at home within 30 days, mail out or drops it off at LabCorp within 24 hours of collection. The performs the test at home, we give them 30 days, but just so you guys know, I know that as CHWs, you're reaching out to them as well, but so do we. So by week 2, if we haven't gotten a result back, we give them a call and we send them a postcard saying, please take that FIT test. The colorectal services, we do the FIT test, the colonoscopy, care coordination, transportation help for GI visits, and reminder calls and letters. Also, we're noticing in the South we're having more and more people who can't afford like their follow-up visits and all that. So the transportation isn't just for the colonoscopy, but it could be if they don't have a ride to pick up the prep kit or they don't have a ride to get the results, we will pay for those as well. What is a FIT kit and what does it contain? It contains the FIT test, the enrollment, and the consent form. The LabCorp rec form, which again we've highlighted the areas we needed filled out. Please make sure that you're sending our lab form in and not your facility's lab form. We've noticed a few, they'll send theirs and ours, and what happens is generally the provider gets billed and not us. So just make sure you're using our LabCorp slip. The FIT kit is prepackaged. It's got a bilingual welcome letter in English and Spanish, the what to do, what not to do, and their care coordinator's phone number and email address. The LabCorp maps, RAC card to refer a friend or family member, the LabCorp FIT kit itself, the one that LabCorp gives us, it has, again, bilingual instructions, step-to-step pictures, the sample deposit, paper to catch the stool, sampling bottle and tube, absorbent pad for sampling bottle and tube, and the biohazard bag for the sampling bottle and tube. And then we do a prepaid LabCorp envelope in there as well. And when you guys get those kits are completely made for you, and then the enrollment form and the lab slip is stapled to the front of it. So Copayment Assistance Program, the CAP program. This is for both programs. It is for someone who cannot afford their copays and deductibles, and really from that, 0 to 250% of the FPL, just because someone could afford their insurance doesn't mean that the copays and deductibles are manageable, and a lot of times they're not. They have to still meet all of our requirements for both programs, and then we will reimburse the provider's deductibles and copays up to 100% of Medicare service reimbursement. The thing with this is they a lot of times, because you can get your screening mammogram paid through your insurance, but you can't get a diagnostic mammogram paid. So a lot of times you may have, the woman has already had that, but doesn't know how to pay for the bill that's coming after. You could still send them to us after the fact, and we could try to get them on the program as long as they meet the rest of our requirements to be on the program. Forms and documentation for Women's Health Connection. These are what our cards look like. We came up with a card thing a few years ago to track, so we were able to track the number of women screened by a card. It's easier for the imaging facility because it gives them something that says, yes, they're not only do they have the referral, but they're on the program. So as you will see under the ID, it always starts with 1819. That's the fiscal year we're in. So the 18 is for this fiscal year. And then it has, I believe, our new ones have our fax number on it. I've added some new stuff to it recently. But the yellow card is the Women's Health Connection card, the 40 to 64 years old. The blue card is for the cervical expansion, the 21 to 39 years old. The green card is for the CAP program. And I know it's kind of insane all the different colors we have, but it does help at the clinic level when you guys are really busy. You know which, it's easier to have a color go with an age group when you guys are so busy. So here's what our enrollment form looks like. So Social Security, a lot of times that doesn't get filled out, but the date of birth, the age, all this information we have to have, especially the name, the first name, age, and the phone number. Every once in a while we'll get one with no phone number, and then we're reaching out to you and harassing you guys for it. So if you guys could double check it, would be insanely helpful for us not to then come ask you guys later. All the breast history and cervical history questions, we need those answered. The questions on this form we have to have to meet our state and federal requirements. So if they don't know, if you would just have them put NA, or if you could on their behalf, and then again, same thing, we're not reaching out to you going, what's the answer to this question? Do you guys have it? We do also reach out to the woman a lot of the time as well. And then they have to do a signature on the back, and then the text messaging if they sign the consent. So forms and documentation for the colorectal program. Again, if it could be completely filled out, you have to fill out all the, name, phone number, all that, and then there's a same thing. Have you ever had any of the following, and have you ever been diagnosed or had a family member been diagnosed? And then the general history area there, same thing, fill it all out, make sure they sign the back page, and then get it faxed to us. So we'll go over the colorectal's high-risk participants. They should go straight to colonoscopy. So if it's one thing we're noticing, so it's a father, mother, brother, sister, or if they have a half-brother or sister that have been diagnosed with colon cancer, they can go straight to colonoscopy. Not if their uncle did, not if their grandfather did, it's just this group. And that is on all the cheat sheets we give to you when we go over the program one-on-one with you. So if they've ever been told they had colorectal cancer, if they've ever been told they've had colorectal polyps, precancerous polyps, a family member, again, mother, father, brother, sister, half-brother, sister, yes, straight to colonoscopy, and then you'll see at the bottom, instead of marking fit, you'll circle colonoscopy, and then if you have 24 hours to fax us that enrollment. Once you fax it to us, we reach out to the member. We tell them where we're referring, which GI doc they're being referred to. We send the referral to the GI doc, and it all goes from there. Fax and email. I've added Lena's information will be at the end of this, but the reason why we put this in for the fit tests. So she gets tons of these a day from all of you guys, and it's a little different than Women's Health Connection. So if you shot her an email, like I sent, Mike Jackson's, and this is his date of birth, it's a little easier for us to keep track of and who they come from, because sometimes the enrollment won't have a provider on it. This way we're able to go through our emails and go, okay, this goes to, say, Northern Nevada Hopes, or this enrollment goes to Nevada Health Centers. So it makes it a little easier for us. Responsibilities and procedures for Women's Health Connection. Provider responsibilities, review the eligibility form to make sure it's complete. Verify informed consent has been signed, which is the back page, plus I think on the front we just added initials as well. Educate participant on services provided by Women's Health Connection. If you guys could let them know that, yes, you're giving them this part of Women's Health Connection, but if there's an abnormality, that we would be calling them so they know there is somebody else calling them. It tends to freak them out a little bit. Distribute the Quit Now brochure to current smokers. Physician to complete and sign annual screening services form. Discuss exam results with participant and indicate any concerns in the notes field that is on the form. Complete the mammography, ultrasound referral form as needed, and fax Women's Health Connection the PAP results. If it's abnormal, please fax them within 48 hours to 284-1918. Make sure after this, if you guys don't know if you have your encrypted FTP site that we set up with every clinic, let me know if yours isn't, and I'll help you get that set up, and then you won't have to fax it. You just kind of drag and drop it into a folder on your desktop, and it's completely encrypted and safe to use. Referral to a specialist. The PCP clinician must complete, sign, and date the first section of the specialist referral form. Provider must fax the referral along with the imaging and pathology results to Women's Health Connection within 48 hours of results received. it's very important that we don't just get just the referral, but we have to have the referral and the imaging and pathology results. Sometimes one or the other is missing. We will then, the care coordinator will assign a specialist to that member, and then the Women's Health Connection will process the specialist referral from there. And you guys can call at any time and ask where we're at in that, but I think the care coordinators are pretty good about reaching out to each clinic and letting them know where we're at with getting them to the specialist. Screening mammography referral process, you must complete the clinician must complete the ordering form or ultrasound at time of clinical breast exam, clearly marking which services are being ordered. It has to be marked. We're lately have noticed that there's nothing marked, and then again, we're calling you back, so just make sure that that is marked before you fax it to us. Women have 60 days to get screened from time of referral. We also reach out to them within that 60 days to make sure they're doing it. Provider must fax a copy of the referral form to selected imaging facility. Provider must give patient a copy of referral for her to turn into the imaging clinic. Provider must submit mammography referral with enrollment and HCFA 1500. Reimbursement and billing. Women's Health Connection eligibility enrollment form must be received within 30 days from the date of service with the HCFA attached and any test results and the mammography referral. All claims for services provided to eligible clients will be paid once a month within the fourth Wednesday of each month. According to NRS, we can now take electronic signatures, including the HCFA forms. So a good chunk of all of our clinics have completely went paperless. We encourage you all to do so. It makes it saves everybody money in the long run. CPT code reimbursement schedule. You all have copies of these and what we do and don't cover. As you all know, and if your billers ask, when they send stuff that is off of our CPT code list and we deny it, if they're able to change it, they have 30 days from the day we denied it to fix it. So the Medicaid Treatment Act. So this is, I think, one of the most awesome parts about our program is women who are on our program who are able to qualify for our breast and cervical Medicaid, if they've been diagnosed, they would have to be under the age of 64, uninsured or underinsured, must not be eligible for any other Medicaid eligibility group, must have been screened under our program, must be found to need treatment, and must be a documented citizen of the United States. So if they're all those things, we can get them on our special breast and cervical Medicaid. But the unique thing is it goes up to 250% of the federal poverty level. So it's not like normal Medicaid, which is 138% of the federal poverty level. So we have our own Medicaid coordinator at Medicaid. So the woman comes to us, she fills out the form. It is 2 pages. It takes maybe 5 minutes. We tell her everything to bring prior to coming to fill it out with us, and then we send it in on her behalf. And we have, generally we know within 5 days. Right now Medicaid is they are so caught up in doing such an amazing job. We are knowing within 24 to 48 hours if the woman's eligible. If she is, they will give us her Medicaid number, and her card, I think, comes 7 to 10 business days later. She'll get her card in the mail, but with that number, a lot of the oncologists will go ahead and take that number and start setting up her appointments for treatment. Provider program support. Every year we update our manual and we give multiple copies out to the clinic. We do a Women's Health Connection cheat sheet. It's kind of the down and dirty when you're super crazy busy in a clinic. You guys needed that information right at your fingertips, so we have that. We have the CRCCP algorithms. We give it to you laminated, but there's an app, which is like $9.99, I think, for the app, and that's what we use on our phone. We do quarterly newsletters. I send out reminder emails about stuff, actually, whenever I feel there's something new going on, I just send an email. Annual provider training webinar that you would do end of June, early July, in services as needed. Even after this, if any of you feel you need a one-on-one where you could sit down with one of the care coordinators, Griselda, or myself, we'd be happy to go to your clinic and do that. Each clinic has their own designated Women's Health Connection care coordinator. Weekly phone meeting with a designated care coordinator. We started doing the weekly phone meetings, I think about a year and a half ago. So on our really big clinics, it's really nice for them to meet once a week, get on the phone, you guys tell us we need this, we tell you what we need, and then it's like it just gets it all out of the way once a week, and then no one's waiting on each other. We have a Women's Health Connection and Colorectal Facebook page, and we have a designated page on the AHM website. On that website is all of our forms that are PDF now, all of our information, our cheat sheets, our manual. You could also find it there as well. Responsibilities and procedures for the colorectal program. The provider responsibility, again, make sure that eligibility enrollment form is complete. Verify that it's been signed, that they're giving us consent. Educate participant on services provided by CRCCP, that yes, we will pay for the FIT, and if it is an abnormal result, that not only would the provider be calling, but so would the colorectal care coordinator. Distribute the Quit Now brochure to current smokers. FIT kits cannot be distributed without determining eligibility and obtaining consent. Access to healthcare must receive enrollments and consent forms daily. Obtaining FIT results. AHN and provider will obtain results through LabCorp Beacon. So through the LabCorp Beacon, if there's any changes in any of your clinics, all you do is email me, and if it's a new person who would be pulling that information, I will set up the access. So each clinic has an appointed person that could pull those results off of LabCorp Beacon, as do we. We pull them off as well. And every once in a while, LabCorp Beacon, it will say that you need to, your codes aren't working, your passwords. Again, you have to email me. I have to go into LabCorp Beacon and prompt it to send you something so you can update it. Sorry, that's LabCorp Beacon. It's so weird how they do it. Provider and AHM will inform members of results via a call or a letter. We will never leave it on a voicemail, so if we don't get a hold of them after like 2-3 times, that's when we send the letter. Positive results will be informed by AHN care coordinator within 24 hours during normal business days. Positive FIT results. A referral will be submitted to GI specialist for a colonoscopy by an AHN care coordinator. An AHN care coordinator will inform provider's office and member of the referral. Billing, it's the same thing. Everything's got to be sent to us. The eligibility form has to be filled out accurately. Now, this is the difference. None of the clinics get paid for the colorectal side of it, because you're just handing out a FIT kit. So you guys don't send us claims. The reason why I put this in here is so you understand when we've sent them to a specialist, this is what we're talking about, that we pay them on the 4th Friday of every month. So if ever you have a member bring you in a bill and they're like, why am I getting billed for this? Please send us that bill, so it just means there was a mix-up and the member got billed and not us. And the Nevada Central Cancer Registry. So this is the thing, you all need to report. Don't assume that somebody else isn't going to report or somebody else is going to do it for you. We ask, please, that you all report if someone is diagnosed to the Cancer Registry for both programs. It is so important. This goes to the federal government. The state sees it. Everybody needs to know. It's the only way we know that how many women are getting diagnosed in our state. If you have any further questions about the Cancer Registry, please reach out to me and I will get you in contact with them. And there's their link below as well. Provider program support, again, the manuals, the newsletter. Here's your team. There's Griselda on the left, Sandra, Elena in the middle, who's no longer pregnant. She looks very different now. Then you have Ivy, Denise, me, and Jamie. So that is your whole team. Mariella is not on this picture. I just realized that she's not on this one. And we have Mariella in the South for all of you in the South. So here's all my contact information and all of Griselda's information. If you need anything, I know on the cheat sheets we send out to everyone, it has all the care coordinators' information. If you want that, feel free to email me and I'll get you all of their information. Here's Elena's for the colorectal program. Most of you know she's been on maternity leave, but she'll be back February 5th, so you can get a hold of her. And does anybody have any questions for me?
Dena, we do have one question. Does a woman need to bring her Women's Health Connection card to all of her appointments?
Yes, she should. She should. And is what that eliminates, if she doesn't have her card, is that, say she's gone to her PCP, but then she's going to imaging and she doesn't have her card, a lot of the imaging clinics will reach out to us just to double check. So if she has the card, it eliminates that process for everyone.
Okay. Does anyone else have a question they'd like to type into the chat box? Give a minute or two in case anyone is typing. Looks like for the copay assistance program, you said it could be used for colorectal cancer?
Yes, it can be used for colorectal as well. But again, a screening colonoscopy would be paid for under insurance. It would be a diagnostic colonoscopy when their copays and deductibles would really start coming in. But again, they probably would have already had that colonoscopy, and it would you would then be reaching out to us after the fact. So yeah, how do we go about asking for assistance for this? If someone goes to you guys and asks, call Griselda or I, or the care coordinator who generally helps your clinic. So say it's Hopes, Northern Nevada Hopes, and Sandra's your care coordinator. Reach out to you, her, and we'll set it all up and do it. We don't give you guys the tools to do it in the clinic because it's very time consuming and we have to call the insurance company. So we actually do all of that on behalf of the woman.
Another person wanted to know if this presentation would be available for ongoing staff training, and it will. We are recording the presentation. So the video recording will be posted on the Nevada Cancer Coalition website at nevadacancercoalition.org. And then you click to the Healthcare Providers tab, and all the way at the bottom of that tab, you'll see a page for the cancer screening training modules. So when you click through that, there will be two modules, one for breast and cervical cancer and one for colorectal cancer. And you'll be able to find the recordings in there along with additional tools, some helpful videos. So if you're looking for a video that demonstrates actually how to complete the FIT test, what happens during and after a colonoscopy, infographics on breast, cervical, colorectal cancer, all of those resources will be available in those modules along with recorded webinars and the post-tests. Any other questions? All right, well, that looks like we don't have any other questions. Thank you so much to everyone for joining us today. And if you do come up with a question after the fact, you can contact Dena Miguel at Access to Healthcare Network, Kellie Ducker at the Nevada Division of Public and Behavioral Health, or me, Kristen Power, at the Nevada Cancer Coalition. Thanks, everyone, and have a great day.